Thank you, Dr. Namrata, and a very good morning to all of you. I'll be talking about the ACANTHAMOEBA keratitis. Now, fortunately, ACANTHAMOEBA keratitis is not so common. However, if it occurs, it can have devastating complications and consequences. The major risk factors are the contact lens users, and particularly when these contact lens users who not use the lens properly, like they use homemade saline to wash it, or they use contaminated water, or they swim occasionally with contact lens, or they sleep wearing contact lens, then they are more at risk. Or there is trauma with contaminated water, and of course orthokeratology has also been implicated, although in only those patients who have used tap water using orthokeratology, they have had this infection. Typically it is unilateral, and it is marked with severe pain because of radial keratoneuritis. And this is typically seen in immunocompetent individuals. But those who are immunocompromised, like HIV positive individuals and in diabetics as well, these may be painless as well. And many times it is diagnosed when the ulcer fails to any treatment like antibacterial, antiviral or antifungal therapy. So the typical symptoms are pain, redness, photophobia and blurring of vision as in any other corneal ulcer, but once again emphasizing on severe pain which requires multiple therapy for pain relief. On examination in initial cases, the initial signs will be some epithelial irregularities which can be punctate or linear irregularities. They can be dendritic form appearances, and this denotes the early disease. Now, these are pseudodendritiform because they don't have terminal bulbs as seen in viral keratitis, but they look like dendritiform. And then you can have these patches and radial keratoneuritis, that is perineural infiltrates. As the disease progresses, you have this typical ring ulcer, and then further progression results in melting and perforation of cornea. So it's very essential to be very active and aggressive in terms of treatment of ACANTHAMOEBA keratitis. Now this is the case with the typical ring infiltrate, as you can see in a proven ACANTHAMOEBA keratitis. Now the disease takes a lot of time in terms of its progression and takes a lot of time in terms of its resolution as well. So once there is an ACANTHAMOEBA keratitis, it's a long therapy that is required in these patients. Typically, they don't have neovascularization. However, if there is scleritis, they can have peripheral vascularization, as you can see here. And scleritis can result in very severe form at times. Now, this is one case which recently we had managed. This patient had migratory scleral nodules. In one area it occurred, then it resulted in thinning, then again it occurred in another area. Again, in a similar manner, it caused a lot of thinning, and these patients require aggressive immunosuppressive therapy, which I'll be discussing. The diagnosis is based on corneal scrapings. The contact lens, if somebody is using, can be sent for culture, the case, contact lens case, the solution, CONFOCAL, biopsy, and PCR. Now, CONFOCAL is something which is very useful in ACANTHAMOEBA keratitis. And in many series, people have started therapy based on findings of CONFOCAL. And you typically see a thickened nerve. And as you can see here, it's a thickened, inflamed nerve seen posteriorly. And as you move further anteriorly, you get to see these double-walled cysts. And then as you move further anteriorly in the cornea, in the basal epithelium, you get these prefectile trophozoites. So this is typical CONFOCAL picture of ACANTHAMOEBA keratitis. Now, trophozoites are difficult to distinguish from macrophages, and they are not very good as far as staining is concerned. But cysts, typically, they stain very well, and they stain with chalcofluor white, methenamine silver, and PAS. Now, typical apple green fluorescence as seen in chalcofluor white staining. Now, cultures are typically and usually done in non-nutrient agar with live or killed gram-negative bacilli, that is Escherichia coli. And the findings that we get is trails and depressions. Trails or depression, they mean the same actually. So you can get the same in macrophages and neutrophils as well. But you have to do a serial transfer from one plate to the other, and if you get trails and depressions on serial transfer in another plate, this means that it's a live acanthamoeba and not macrophages. And polymerase chain reaction, as it is fast becoming, and particularly the real-time PCR is fast becoming a very popular method as far as the diagnosis of acanthamoeba is concerned. The therapy is a combination therapy, and it holds true. It is useful, it is successful. We typically give a combination of bigonide and diamidines. Bigonide, like polyhexamethylene bigonide, 0.02%, or chlorhexidine, 0.02%. And these are typically prepared in pharmacies, so you need to have a pharmacy backup for that. And diamidines are available, propamidine, 0.1%, not that freely available, but you can get in some shops. And these are started initially 1 hourly for 48 hours round the clock, and then accordingly, it's not a hard and fast rule that you have to taper immediately on at the end of 48 hours. You have to judge the response, and accordingly you have to reduce it. Topical steroids are given if there is mild scleritis or even in severe scleritis. Patient is in severe pain, and it is given under the cover of bigonides. And once the inflammation, anterior chamber inflammation or scleritis subsides, you can reduce it, you can stop it, and continue with your bigonide therapy, which is required on a very long-term basis, that is 6 months to even 1 year sometimes. Now, in very advanced scleritis, as the picture that I had shown earlier with scleral thinning and all around, it's very essential to control the inflammation. And these are actually immune-mediated against acanthamoeba, so these are all immunological. So you have to give systemic steroid in order to control it. At times, if it's not controlling, you have to give a bolus pulse steroid as well, particularly when there is a recurring scleral nodule and scleral thinning. Mycophenolate has been found to be quite effective, and it is given in increasing dose. You start with 500 milligram twice a day, then after 3 to 4 days, you increase it to 1 milligram twice a day, and later on you increase to 1.5 milligram twice a day. And in some cases, in very severe cases, as I had shown in the picture, cyclosporin 3 milligram per 3 milligram per kg per day is given in divided doses, 2 divided doses. Now, in a severe case, you may have to combine all these, systemic steroid, mycophenolate, as well as cyclosporin. So this is the typical regimen that is given in advanced, very severe scleritis in acanthamoeba. Then, of course, in systemic therapy with azoles and voriconazole, 200 milligram twice a day is quite effective. There are some newer treatment people have tried, collagen cross-linking, in order to burn the acanthamoeba. But these are just one-off case reports, may not be considered or may be tried by somebody, but still it is not the gold standard. Then phototherapeutic keratectomy has also been found to be effective in a couple of case series, and one may think of trying it. And of course, in the end, if nothing works, then we have to do a therapeutic keratoplasty. But if you are doing therapeutic keratoplasty in acanthamoeba keratitis, then it is always advisable to try to control the initial infection. If the infection is controlled to some extent and there is marked inflammation resulting in perforation, you can go ahead with a therapeutic keratoplasty. Thank you.